Okay, so good evening, good morning, good afternoon from wherever you may be joining. Yes, this is should I call it the pediatric arm of the American Thoracic Society? I don't know whether you've been able to join any of this series, but this is our opportunity to share interesting pediatric pulmonology cases managed from all around the world. And this evening, we'll be having two interesting cases. Been part and parcel of managing these cases, but um, this one will be presented by Professor Chizalu Ndukwu. She's a professor of pediatrics, and we manage this case together. And without letting the cat out of the bag, she would give us this case. She'll share her slides, and she'll take it on from there. My intern, Dr. Cyril, who I think because of a network has not been able to join, but it's also a case I managed in South Africa when I worked there. So it's interesting African cases. And that one also, I will not let the cat out of the bag till we start discussing it. So when we get there, so I hand over to Dr. Professor Ndukwu. Once we're done presenting these cases and trying to discuss it with you. And, as interesting as they may be, but I'll let you put your questions in the Q&A. The other faculty that are also here, Daniel is here, Osge is here, Laura is here, and so that we'll discuss this interesting pediatric pulmonology cases and then take the questions together. So over to you, Zalo.
All right. So good day, everyone. We'll be starting with a case of post-tuberculosis lung disease, and with emphasis on the imperative for follow-up care. We've called it Beyond Microbiologic Cure in Africa because we want to emphasize the fact that for certain pathogens like Mycobacterium tuberculosis, getting a microbiologic cure may not spell the end of symptoms. So we'll be looking at a case, and that's a 20-year-old Nigerian female who was referred to us at a private pulmonology facility. So she presented with a history of having completed treatment for rifampicin sensitive TB 2 years earlier. However, her symptoms had persisted, and she presented with productive cough, dyspnea, which was progressively worsening and worse with exertion, low-grade fever, and the feeling of being down and feeling sad. So the initial evaluation from the referral, it was a presumed recurrent TB case. She was ill-looking, afebrile, mildly pale, but she was in respiratory distress and her oxygen saturation in room air was 87%. She didn't have pleural effusion, but she had diffuse rhonchi on the chest. Now the imaging, the chest x-ray just showed hyperinflation on the right lung field and then scattered opacities on the left lung. Then the chest CT, as we can see on the right side, showed distortion of the lung architecture. On the left lung, we can see cavitations, fibrosis, and evidence of traction bronchiectasis. You can see all those white spots that are blood vessels. And then if you zoom into the lung, you'll see that the bronchi are quite obvious. They are dilated, they are bigger than the blood vessels, and the walls are quite obvious. On the right lung, we can also see some scattered bronchiectasis, evidence of fibrosis, but no cavitation on the right, and there was no pleural effusion or lymphadenopathy. We couldn't do spirometry on her first visit because she was too ill. However, on subsequent visits, spirometry was done, and the FEV1 was quite low, and they demonstrated a 9% change post-bronchodilation. FVC was low. In fact, all the lung parameters were low, so it demonstrated a mixed picture of both restrictive and obstructive changes. The laboratory results, the ESR was high, the C-reactive protein was high. However, the gene expert was negative. Well, our ability to do some investigations to, confirm whether there was non-tuberculous mycobacterial or fungal infection of the chest was limited because of resources. So our diagnosis was post-tuberculosis lung disease with bronchiectasis, cavitation, fibrosis, and destroyed lung syndrome. The differentials we considered included recurrent tuberculosis. From the history, we did not get any history of, recurrent lower respiratory tract infections from childhood or poorly treated pneumonia. So that was ruled out. And then we also considered non-tuberculous mycobacterial infection. Now, why did we consider post-tuberculosis lung disease? The CT findings were quite classic, like I said earlier. And then the gene expert was negative, and then the spirometry was quite suggestive. And the fact that the patient had symptoms persisting, even though microbiology had said that she was cured from TB, and then we're able to exclude other causes. Now, what did we do? We employed both pharmacologic and non-pharmacologic treatment, as in standard guidelines. So the patient was placed on antibiotics, IV initially, levofloxacin, and then we converted to oral. Then she was placed on azithromycin 3 times a week as a kind of prophylaxis. And of course, we'll talk about other things that azithromycin does for patients that have bronchiectasis. Then she was also placed on inhaled corticosteroids and on mucolytics. For non-pharmacologic therapy, we involved the physiotherapist. So she got chest physiotherapy. She also had postural drainage because of course, we know there is that preponderance of mucus plug and thick mucus. Then she was malnourished actually, so she had to get nutritional support. And for her mental health, we had to do some counseling. Now, the antibiotics they were given because we felt that the patient had an exacerbation at the time of presentation. So that was basically what the levofloxacin was dealing with. Then the azithromycin had like 3 things to do. In addition to dealing with the colonization, we also know that azithromycin has anti-inflammatory properties and can also help with lightening of the mucus for easy, clearance. The ICS was given to reduce airway inflammation, even though we know that current evidence has shown that in bronchiectasis, most of the inflammation is neutrophilic, but still ICS is given and it still gives some response. And we know the patient came with obstruction of the airways as evidenced by the rhonchi. Then the mucolytics were given also to improve mucus clearance. Of course, the physiotherapy for the mucus to enhance mucus clearance also. Of course, the nutrition would improve her immunity and improve outcome. And then we needed to address the psychological burden the patient had faced for some years. And then, of course, PTLD is chronic and progressive, so there is need for follow-up. So the patient was followed up and is still being followed up. So what was the outcome? Well, we were able to achieve a clinical stabilization, which was why we were able to do spirometry on subsequent visits. There were improved symptoms, but like we know, some of the changes we had in the lungs are irreversible. So there's still evidence that she still has a structural lung damage, and the spirometry changes have not been remarkable. So for that patient, there's ongoing need for long-term follow-up. So TB treatment success does not guarantee full recovery, as we all know. And up to 30 to 50% of TB survivors have been known to develop long-term lung impairment. In Nigeria, patients that have had bronchiectasis, they found out that over 50% of them have had TB, either one episode of TB treated or recurrent episodes of TB. So what is post-tuberculous lung disease? A constellation of chronic respiratory abnormalities attributable to previous TB infection and usually occurs following microbiologic cure. It's common, but often misdiagnosed as recurrent TB, especially in low and medium income countries where we have issues with diagnosis. So there is major burden in low resource settings, and it includes both the physical, psychological, and socioeconomic consequences. So when a patient presents like that one, this index patient, it's important to exclude active TB like we did in this patient with the gene expert coming out negative. And it's also important to exclude other possible lung diseases like we did in this patient. Then it's important to note the common features like we had in this patient. The patient had bronchiectasis, had fibrosis, cavitation, and had airflow obstruction, which are classical for post-tuberculosis lung disease. So it's essential that we recognize the importance of spirometry and CT. In fact, CT has helped to improve and increase the diagnosis in LMICs and in other countries. It's also important for us to note the significance of the mental health burden of post-tuberculosis lung disease, and also to recognize the fact that diagnosis is often delayed due to resource limitations, as we have in LMICs.
View this full video at atsnow.thoracic.org.